This conference will now be recorded. This conference will now be recorded.
No? No, Steven?
My business.
Yes.
I just assumed that you would.
No.
That's probably why.
I can't, I'm about to
You
start
probably went
lecture.
down a mountain lost.
I gave you a healthy option.
And I ran through them.
You're only supposed to have 2 a day.
He's all, man, you just hold on because.
Maybe you can do 3.
Yeah, you still didn't catch it? All you gotta do is move your hand. Oh, was that your excuse?
I would like the raspberry ones. They don't have them on their site. No, I would. They have 4 flavors. I got watermelon, and I don't really like the watermelon. I don't like it.
You just tell me it wasn't to you? What do you think? What did I do?
Come on, dude. You're killing me.
Can you bring me one too, dude?
Yeah, man.
You guys wanna play like this? Y'all wanna play? Y'all funny wanna play? Y'all know I can't have snackies in here, dude. Now you wanna play
I
games?
got a question. What is the wing speed velocity of an unladen swallow?
60 knots an hour.
On there now. That's a new flavor. Oh, when I ordered watermelon, I didn't have it on the website. They have, yeah, I ordered it.
Damn, dude.
I'm hungry. You don't give me lunch breaks.
Damn.
HR.
It's right in notes over
Yeah.
there.
Technically, we don't get like an uninterrupted lunch break.
You know that this actually doesn't count as a lunch break.
Why not?
You never asked for a lunch break.
I gotta ask.
You get paid round the clock. You get paid through lunch.
Look, she's writing it down right now. No lunch break.
Tell Bert Gosh. Okay.
Strongly worded email tomorrow. Just know.
All right. Does anybody have any questions off of what you guys tested on or what we've gone over the last couple of weeks that Chaz and Becca have been gone? Yeah, just go with your gut, man. Every study shows that going with your gut is going to yield you a better result. That's data. That's not just anecdotally. We're like, oh yeah, just go with your gut. No. Like that's the studies have shown. If you go with your first answer, you will have better test scores. Okay.
Question.
Yeah.
For compressions, if you're by yourself, I don't know what adult is 30 and 1.
30 to 2. 30. Yes. So an adult across the board. Yes. Yeah, adult across the board, no matter what. 30 and 2 until there is a advanced airway in place. Then you go to continuous compression.
Okay.
That's a good question.
Child 30 and 1.
Child is 30 to 2 with one person, 15 to 2 with 2 people.
So it's 2
So the advanced airway, whatever is in place, the compression to what shoot for is like anywhere from 90 to 120, right?
100 to 120. 100 to 120. So yeah, 100 to 120, and you're looking for 2 to 2.5 inches, complete chest recoil, 100 to 120. Okay, and then early defibrillation is your key to saving somebody. Okay, well, if nobody has any more questions, we'll dive into lecture. Today is going to be chest and abdominal trauma. We're building off of our trauma packages and what we've been going off of. Again, what I will tell you before we start this, the difference between good and great is you knowing your anatomy and physiology. Okay, understanding what is happening in the human body will help you treat it effectively. Okay, our objectives today, we're going to review A and P of the chest and abdomen. We're going to talk about injury patterns of the chest and abdomen and how to treat them. Review lethal triads and why it's important in treating trauma patients. And when something has triad around it, you should really pay attention to that because that's something they're going to cue in on a test. You should know it for the real world too, right? But in the moment, do you really know, like, is the trauma diamond of death going through your mind when you put a tourniquet on someone? Probably not, right? It's important to know, and it's important to, because you're going to get tested on it, but it's not going to come to play like right in the moment. Okay, A and P of the chest. So you have your chest cavity. You have 12 sets of ribs, your sternum, thoracic spine vertebrae, scapula. Can anyone tell me where your scapula is? What are these? What are these? These are your clavicles. Your scapula is back here. Fun fact, this is one of the hardest bones to break. So if you have someone with a scapular fracture, you need to have a high index of suspicion of other really bad injuries. Your heart, you have large blood vessels, obviously, to supply blood to and from your heart and your lungs. And then your respiratory function. Pop quiz, how do we breathe? Negative or positive pressure? Negative pressure, good. All right, mechanism of breathing, your chest wall, diaphragm, and the lungs work together. The active breathing is an active process, and exhalation is a passive process, okay? And they have a good little video in there that demonstrates that.
What happened to the little bucket? Cheese balls.
Somewhere over here, yeah. So I want you guys to realize, like, when you breathe, it's not just your lungs expanding, right? You have a lot of movement in there. Your diaphragm in its entirety is moving up. Okay, A and P of the abdomen. This is gonna come into play. You absolutely should know where your organs are, what are hollow organs, what are solid organs, and the injury patterns associated with them. Okay.
What?
That's a good question.
The
Gallbladder?
gallbladder is hollow.
Yeah, it's
Because it
hollow.
holds
Hollow,
blood.
Yeah. So you guys see your right upper quadrant has the gallbladder and the liver. That thing is big, and you can see it transects into your left upper quadrant. Your spleen and your stomach are in your left upper quadrant. And then basically everything in the bottom is small intestine. And then everyone knows where, because everyone knows someone who's had an appy, your appendix is in the right lower quadrant, and then your bladder. Okay, why do we think that hollow organs tolerate trauma well when solid organs don't?
Absorption of impact, probably.
Yeah, right. There's room to compress and expand. Okay, but when you have a solid organ that doesn't have room to compress and expand, that energy, what law of Newton is that? That's a good question. I have no idea. I'm glad you answered that for me. No, but really, right? You have energy that is traveling, and that energy is going to stay in motion. So with your hollow organs, there's room to compress and expand, and your solid organs is not. Those organs are way more susceptible to rupture. They have more vasculature. They hold more blood. Okay, so you need to know what solid organs are: your spleen, your liver, pancreas, and kidneys. Those are going to be the ones that are going to cause you the most trouble in abdominal injuries and thoracic injuries. Man, my voice is full of shit today.
Kind of like punching a balloon versus punching a sponge full of water.
Yeah, I think that's probably not a bad analogy. I actually think that's a pretty good analogy. So your hollow organs is your stomach, gallbladder, duodenum, large intestine, small intestine, and bladder. Physiology of abdominal organs is dependent on individual function. Abdominal cavity is dynamic depending on location of diaphragm. Like we just talked about, everything moves when you breathe. There's always a large volume of blood in the abdomen. Okay, as we see like all of this here, right? Everything in the body needs blood that's delivering oxygen to it, and your organs are no different to stay alive. So these are constantly being fed, just like your heart and your lungs are.
What are those blood vessels called again? The ones that are within your hips?
So you have your like femoral arteries
That's it.
that go through there.
Aren't they something else a little bit further up, like right where they split from the,
Talking about you do your VK.
it's like
Probably.
right after they split. from the kidney. They're called
Is
something.
which, are we talking arteries or veins?
Well, you have both.
Iliac.
Yeah, you have both that run through there.
Iliac.
There.
Yeah.
That's it.
All right, we're gonna get into some problems with your chest and abdominal trauma and why it's so important that we recognize these and treat them effectively. Okay, disruption of breathing, hemorrhage and shock, disruption of organ function, infection. Can anyone tell me what that picture of the lung is? What would you guys call that? Hemopneumothorax, right? Because you have blood that's putting pressure on the lung. And then what kind of injury would you call this with the intestines showing? The evisceration. Good. There's something else I wanted to cover here. Okay, so disruption of organ function. So if you have like a bad injury to, let's say, one of the organs that is the filter for the body, right? What organ is that? The liver, okay? So if your liver is damaged by blunt force trauma, yeah, it may not be a disease process, but you're still inhibiting the liver's ability to function, and you're hemorrhaging blood into your abdominal cavity. Yeah, I can.
And then question, how long does it take typically for your check liver life?
So it depends on the disease process. Like if it's coming on because you're a chronic alcoholic, it could be a long time. If you got shot through the liver, it could be pretty quick.
Yeah.
Yeah. I mean,
You'll still see that yellow jaundice color.
That's a good question. I've never seen it off of a trauma, but I haven't really had a bunch of liver lax. I would assume it probably actually takes a little bit of time for that, like, to disperse and turn the whole body yellow.
Yeah,
Mike, have you ever seen it?
I don't think you would ever see that in the pre-op sense.
Yeah.
Like in the
Okay.
hospital.
So Calvin wasn't yellow until.
Calvin was not yellow. Yeah. Okay, blunt force trauma. You can fracture ribs, sternum, costal cartilages. Painful, but not usually life-threatening. I mean, people have broken ribs all the time, right? The only time it's really going to affect and be like a fairly legitimate life threat is if you have free-floating ribs and it's disrupted your ability to breathe in an adequate fashion. And then if it lacerates blood vessels or lung tissue, because right, you break off your ribs and they're jagged and they start stabbing things.
Is that the flail chest?
This would not be a flail chest, but yes, yeah, what I'm talking about is a flail segment. Yeah, I would say so. If you have two sections of rib that are broken off in its entirety, and now they are not moving in unison with the rest of the chest, yeah.
And that paradoxical.
Yep, paradoxical motion. Good job. That's a good job. Rib fracture treatments, honestly, there's not even a lot that we're going to do, but pain management, allow the patient to remain in the position of comfort. If they have had a bad enough impact, this is what I would kind of constitute as a distracting injury, right? Like if they were in a rollover and were ejected and they have broken ribs, like really consider putting a C-collar on them, treat hypoxia if they're not breathing well, and then allow the patient to self-splint. So what we've learned in EMS over the last 10 years is that when EMS tries to immobilize people, it actually causes more damage. The body will protect itself better than we can protect it. So allow them to self-splint. Flail segment, fracture of 2 or more consecutive ribs in 2 or more places. Did we watch that video of the guy that had the massive, okay, cool. Yeah. Inadequate breathing or hypoventilation. Paradoxical motion, good job. Then there's a good little picture. And the way we have treated this historically has changed from like every 5 years to every 5 years. Oh, there's a really good flail chest right there.
Almost looks like you drank too many Red Bulls.
If you see a flail chest, there's not a whole lot you can do for this besides comfort care, but you need to have a high index of other issues going on, okay? It takes a lot of force to do something like this.
That's only if it's open.
Yep, if it's open, now you have a sucking chest wound, and then you apply an occlusive dressing.
Then if you have to make one, the reason you take only like 3 sides of it is to maintain the body like. pressure,
Yep,
right?
you want that ability to ventilate, right? You want to just restore, think about this, you're just giving back what the body does naturally. You're restoring normal physiology. So you're allowing the air to escape when it's supposed to escape, and you're occluding it so it doesn't come in when it's not supposed to. Yeah, you can exacerbate a pneumothorax and make it worse. Okay?
Then
So-
doesn't that depend on like how fast you get in response with an occlusive dressing? Because if that air is already in there, in the lungs, I mean, you already have like a pneumothorax, your occlusive dressing isn't gonna do anything, right?
Yeah, yeah. Theoretically, it should still let air escape, but there's a high likelihood that it doesn't, and now you're rocking a tension pneumo. So whenever we put an occlusive dressing on somebody, we are taking Q5 blood pressures and monitoring their respiratory rate and their SpO2 status, because the first indication I have that their blood pressure is dropping, I can peel that off and try to vent it a little bit. But there's not a lot that really even we can do for like a really bad tension pneumo. Like we can stick a needle in their chest, but even that has a pretty high failure rate. So when we're going to treat a flail segment, first, don't get distracted by this. Your ABCs absolutely should come before you even think about treating this. Give them oxygen if they're hypoxic or not breathing adequately. If they are not breathing adequately, then provide them with positive pressure ventilation via BVM. And then, yeah, consider, right, if you've had such a trauma to the chest, there's probably going to be blood in that cavity or air forming. So you have to have a high index of suspicion for a pneumohemo. And then do not restrict the chest wall movement. When I went through EMT basic school, it was like, put sandbags on there. And we found out, like, that's garbage. Don't do that anymore, please.
Sandbags on the fish.
Yeah, they can't breathe.
Your education.
It's been a long ride. It's been a long ride.
Not better than sticks and rocks.
Okay, penetrating chest injuries, assume all wounds are life-threatening. The thing about chest wall injuries is that once it's like gone through the chest, you really don't know what is damaged in there, and how bad it's going to be, right? The entry wound might look pretty minor, but like you got to remember that tissue reseals, right? It has that expansion in the cavity and then it reseals. So even if it doesn't look that bad, you need to have a high index that it is going to be bad. Okay. Determine the description of object that penetrated. Like my prime example is we had a guy come in with a really small laceration into the hospital in Elko when I was working there, but he got stabbed with like a big old like fillet knife that was actually like really thin, but he had a lot of damage going into his cavity because it went down so deep. Open wounds allow air into the chest. It causes an imbalance in pressure and causes your lungs to go from a tension or a pneumothorax, and then you can progress to a tension pneumothorax. Okay. So someone already said it. When we have a sucking chest wound, we need to seal that with a 3-sided occlusive dressing and restore normal physiology. That's a gnarly chest wound right there. And that, you see that thing, the little piece of plastic off to the left there? That's a chest seal, right? Like they're venting it right there. Probably.
I mean, what are we seeing? What's coming out? Is that the lung tissue?
Yeah.
Okay.
Yeah, that would be some lung tissue. Okay. Air draws into the hole. You can have bubbling sound or an air sound, and then the patient is, I mean, you've taken away their natural ability to breathe, so they're going to have a hard time breathing, and we need to help them with supplemental oxygen. And if we get to a point where they're not breathing adequately, we can breathe for them. Okay, where's your neck and where's your navel? Good, good. Anything from there, we are not packing, they're getting an occlusive dressing. Why do you think we're not packing from here to here? It's an open cavity, right? We don't have enough shit to pack, and then guess what? If we pack it enough, all we're gonna do is create an obstruction for the lungs, okay? So these are being treated with an occlusive dressing. Be mindful that where you have an entrance wound, you may have an exit wound, and that needs to be occluded as well, okay? Because if you only do one side, not the other, you haven't solved the problem.
So would you go straight into the occlusive dressing? No pressure, no?
Yeah, because you're generally not going to hemorrhage from this area. Okay, the big thing that's going to kill them is going to be like the tension pneumo or any internal bleeding, and you're not going to stop internal bleeding with pressure. Now, I will caveat that by saying if you want to start by putting a gloved hand and putting some pressure over the wound with a gloved hand, you're doing the same thing as a chest seal is doing at that time. Okay.
Treating that negative.
Correct. Yeah, restoring
So,
normal
but
physiology.
You're not, I mean, would you, on the exhale, like lift your fist, like the palm of your hand up, or would it be like on the
Yeah, if
inhale?
you have that cognitive ability and you are like with it enough to recognize when they're exhaling and inhaling and you're getting, then if you wanted to occlude it when they inhale and then let it go when they exhale, that would be the most optimal way to do that.
Maybe this is a dumb question. So when they inhale, that pushes the pressure, wouldn't that technically push the air out through the wound? Wouldn't that be when the air comes out?
No, right, because like, remember, like for the most part, like I still have negative pressure, right? Like that balance is not there and it's not working properly, but I still have it, right? Hence why like you're going to include it, because when I inhale, I will suck it.
But if you aren't with it enough, just when in doubt, occlude.
Yeah, fuck yeah. Gloved hand, chest seal. So you're asking like, okay, you suck it in when you inhale, but when you exhale, is it not pushing it out and making it equal again? Was that your question?
Yeah, the question was when, because in my mind, the way that I'm seeing it, when you have that sucking chest wound, it would almost be opposite.
So think of it like if you were to poke a hole in the side of that Utz can, like not where the straws are coming out, like if you just poke a hole in the side, you
Yeah.
pull those gloves down, it's going to pull air into that hole.
Yeah.
And remember, exhalation is a passive process, right? You're not getting that much force generated with it. And then if you already have a buildup of pressure, you're not getting exhalation anyway, right? If that pressure is already if that air is already putting pressure on that lung and on that heart, you're not getting that lung to expand anymore. And that's where the life threat comes from.
I wasn't.
No, it's good. It's a good question. It really is.
I was thinking about like the lungs expanding, but then trying to push that air out, not because the negative pressure.
No, it's a good question though. Like we just talked about, if you put a chest seal on somebody and they start to get worse, take it off and burp it, right? Like try to let a little bit out and go again.
And the signs for that will be decreased blood pressure.
Yep. You basically, your signs of shock are increasing. And then here we have a good couple pictures as to how a 3-sided occlusive dressing works. Yep, just one side to be able to release the pressure that does come out.
Just enough where it does come out, right?
Yep. And be mindful, right? These pictures make it look pretty, but in the real world,
It's not gonna be.
you're gonna have blood everywhere, right? So those will start to occlude. The couple times I've had to put these on, I've gone through 3 or 4 different occlusive dressings on the same person. Okay. This is what we carry. We carry the hyphen vent. If you guys see, this one actually has several different rivets that allow it to come out and then it seals in itself. And this is probably the best product on the market right now. There's like Roush's and other things like that. Those are, I mean, disclaimer, I'm not endorsing any company nor am I endorsed by any, but this is the one that I've had that has worked the best.
So you just thought that one completely on and leave it all down
Yep.
in those 3 areas and went for you?
Yep.
Until, is it like 1 or 2 become included with blood and then the one silver?
I think that's the thought process behind putting the 3.
Or does one act like a drain while the other 2 are?
It just depends, right? If you have blood in there, then it can, but depending on where the blood is and where the wound is, the blood might not drain out. But a lot of times with these, you're not going to fix a hemothorax with this, right? But those guys need a chest tube and they need suctioned out. Okay. Can someone tell me the difference between a normal pneumo and a tension pneumo?
It's in the pericardial.
That's a cardiac tamponade.
That's, okay, so when it's putting pressure on the heart.
Yep, you're getting excessive pressure on the heart and the lung. That's when it becomes tension. With that, you will see a drop in blood pressure, and a very, very late sign will be tracheal deviation. Your trachea will deviate to one side or the other. I've seen probably a dozen tension pneumos and never seen a trachea deviate. I've seen people die from this without ever seeing a trachea deviate. Takes a lot of force.
So it's just basically collapsing the heart to where it's not letting it.
Yeah, right. All that pressure, and this is why it's we call it tension physiology. Where you're putting tension on that heart, and now that heart can't expand the way it's supposed to. You're putting stress on it. Okay, air accumulates in the chest cavity, causing the lung to collapse. By the way, what are we doing for a simple pneumothorax? They have a collapsed lung or a high index of it, but their blood pressure is great. Everything looks great. Yeah, just oxygen. What's that? Yeah, paramedics can do the needle. So you got to be really careful. And I'm glad you said this. That was your question, right? CPAP and
Yeah.
Okay, good. I'm glad you said that, because when you see people that can't breathe from traumas, we want to breathe for them, right? And CPAP is a great tool for people that can't breathe. But if you are putting a copious amount of pressure, you can actually make this worse in a hurry.
No CPAP and
No CPAP in a pneumo. No CPAP in a pneumo.
So would it
Sure.
blow it up too quick, or would it just do something different if you put a CPAP on?
That pressure is basically going to fill up the rest of that or expand that area, and it's going to just,
Tighter?
yeah, you're basically adding like gas to a fire. Yeah.
Going quality tension.
Yep. I know because I killed a lady doing this, and I will never forget that lady's face. She haunts my dreams. Rightfully so. Okay, pressure from the air in the chest cavity, it's pressure on the heart and the vena cava, right? You're obstructing that person's ability to pump blood. Tracheal deviation, late sign, okay? On the test, for sure, tracheal deviation, tension pneumo all day. In real life, do not rule out a tension pneumo just because they don't have tracheal deviation, okay? But on the test, tracheal deviation, tension pneumo. Okay.
You guys will almost probably never see this. Like all the literature supports like tracheal deviation is usually caught post-mortem, like with a CT or.
Yeah. Yeah, and I'm actually surprised that they still keep it in the literature here, to be honest with you. In the next 5 years, I would guess that this is gone from the frequent signs and symptoms.
question, does it deviate towards, in theory, does it deviate towards or away from the lung that's having issues?
Towards the good lung,
Towards the good
because
lung?
that's where all your pressure is coming from. That's the lung that's overworking, so it's going towards the good lung.
Okay.
Jugular vein distension, okay? You're getting that back pressure. Pressure is now filling up into the neck. Your jugular vein is becoming gorged, and you can see them protrude. Absent or diminished lung sounds. There's been a lot of studies that came out that show EMS is trash at listening to lung sounds. So you should listen to lung sounds every chance you get, because if you listen to 100 normal lung sounds, you have a higher chance of catching an abnormal lung sound. But if you just listen to abnormal, like you're not gonna. This is a skill that you have to polish and refine. So absent or diminished lung sounds, And when you're listening for lung sounds in somebody, be thorough. Take the time, put the stethoscope on their skin, and take time listening to each lobe. Don't just like, no, like full inhale, full exhale, do it again. Full inhale, full exhale, do it again on all 4 lobes. And then signs of shock, right? Your difference between a normal or a simple pneumothorax and a tension pneumothorax is those signs of shock. It is that blood pressure. Okay. Any questions on tension pneumos? Okay. Hemothorax. Chest cavities filled with blood. Hemopneumo is a mix of blood and air. What can we do, even myself or Mr. Hoover, for a hemothorax in the field right now? Not a damn thing. Yeah, not a damn thing, right? Unless we had a chest tube that we could miraculously put in and suck some blood out, we're at the mercy of the physiology at that point.
So if it's just a pneumothorax, you guys could do like, what is it? Like poke a hole in them,
Yep.
put your finger in there and be like, ooh.
So we cannot yet. We're working on that. That's a very new thing that's hitting EMS.
Well, not a finger, but like a needle. then.
No, but that, so what you're talking about is something that's coming.
Right.
It is
that's what
coming.
that Jazz refers.
Yep. I think everybody, we're waiting for the state of Nevada to kind of make it common practice so that we can implement it too, because it's actually safer than the needles, is just taking a scalpel, punching through their chest wall. And I've never done it. Mike Hoover's actually done it, so I can't speak to it. I've put plenty of needles in people. The needles fail and the needles are long. So if you mess up, you can actually nick things that you shouldn't. And we've seen paramedics that like go way too low and then they biopsy a liver, right?
Third and fourth, yeah.
Yeah, so second intercostal midclavicular or fifth intercostal anterior axillary. Yeah, I'd say everyone has about the same chest wall thickness. We have really good needles. So ours actually have a vent on them. So as soon as you hit air, it'll start to whistle at you. Or we stick a flush on the back and then create a little bit of pressure. And then as soon as you get bubbles, you know you're in the right cavity. Okay. Signs and symptoms are going to present like pneumothorax, may cough up frothy red blood. But really, there's not a lot you're going to do for a hemopneumo. Kind of tough. Yeah. Compression and shearing injuries, blunt trauma to the chest. This is generally going to be a shearing injury is going to generally be with like a high impact or high mechanism injury. And then chest injuries are either going to be classified as closed or open. It's the same as a bone, right? If the chest wall is open, it's open. If it's closed, it's closed. The other thing, just a tidbit on the side here, is like take the time to look at if you have motor vehicle injuries. Like take the time to look at that car, because that car will tell you what happened. That car will tell you the story. This morning we had one where, you know, our paramedics like went to the car, they looked at it, and they immediately caught that there was airbag deployment. The seatbelt was locked out. They saw the position of impact and how far the car flew, and that cued them into like, oh no, this is a high impact thing. It wasn't a little fender bender. Traumatic asphyxia. Sudden compression of chest, force blood out of the organs and rupturing vessels, may cause bulging eyes, distended neck veins, broken blood vessels in the face. As you guys can see with the guy to the bottom left, what do you guys think that is on his chest?
Like some stretch marks from just trying to expand.
I want to say that's actually a tire.
Oh.
If you look closely to the pattern going across, that's a tread pattern. So what you're seeing there is all of that force being compressed back into that guy's head. Okay, you see the color difference between his head and the rest of his body? Yeah. And then look, right, you can have the bulging eyes, this discoloration. Clearly he has a different color pattern. And then you can see that the color changes to the guy's tongue.
They're not anything
Yeah, that guy's dead.
to.
Yeah, that you're looking at dead people. Yeah. Sorry, I should have warned you about that.
No. I don't know.
So,
What's going on with that second?
He's dead too, I'm sure.
Well, I mean, what, dies?
Yeah, so if you look, he's just got, his eyes are globally bloodshot. They are like bulging, discolored, his veins are popped in there. Think about the amount of pressure it would take to pop all your vessels from the chest up.
A lot of pressure.
It's a lot of pressure.
I mean, is that almost like MCI at black status?
Yeah,
Like,
I mean,
you don't, what can we do if?
you know, if they're dead, if
Well,
they're,
if they're not,
yeah, so if they're not dead, you're literally just running through your ABCs. Because guess what? There's not a lot I can do for this guy.
like, they're going to pass.
Yeah, this guy needs a trauma surgeon and a bunch of blood and a couple prayers, probably lickety split. But if you come across this, you're just going to do your standard BLS resuscitation on this person until somebody calls it. Cardiac tamponade. That's where I put up Beck's triad up there. It's one of the things that is going to, you're going to get tested on. So cardiac tamponade is injury to the heart causing blood to flow into the pericardial sac around the heart, causing increased pressure on the heart so chambers cannot fill. You're impeding that heart's ability to function normally, okay? So think about that, right? You know you have a lot of sacs around the heart. Well, what does the heart do? It expands and contracts. That's how you move the blood. Now think about putting pressure on that heart so it can't expand anymore. Now you're not getting blood in and you're not getting blood out. And the pericardium is a tough sac and it rarely leaks unless you have, I mean, obviously unless you have like a stab injury to the heart, then you'll get some leakage. But from blunt force trauma, this is probably how it's going to end up. Not a lot we can do with supportive care for these. Even us, not a lot we can do. Years ago, they used to let us stick big long needles into the heart and suck the blood out. Such a low rate of survivability. People were doing it to the wrong people, so that got taken out of the scope of practice. I don't know anybody other than ER docs and trauma surgeons that do this anymore. Really the only thing you're going to do. Now, if you're providing supportive care, right, giving them oxygen and doing all the right things, treating for shock, and you get them to someone that can do that, you can absolutely save them. Mike, were you around when pericardial centesis was a thing? Did you ever do it? No.
I wouldn't be terribly surprised to see this come back.
Because of ultrasound? Yeah. I wouldn't either. I think it's going to be ultrasound guided though from now on. Because that was the big sticking point, is that paramedics were doing it to people that didn't have it, and now we're poking holes in people's hearts that don't need holes in there. Yep. Beck's triad. This will be a test question. They always use this as a test question. This is a free gimme point. Okay, so the 3 Ds of cardiac tamponade is muffled heart tones or distant heart tones. Distended neck veins. Think about the physiology, right? Your heart's not expanding, putting pressure on. Now you have your neck veins that are starting to engorge and pop out. And then decreased pulse pressures. Think about it. This person is in shock. So you can either have decreased pulse pressures or low blood pressure is the other way we can say it. Okay? So remember Beck's triad. I will. No problem. Aortic injuries. Aorta is the largest artery in the body. Aortic dissections, inner layer of the aorta begins to tear. Blood flows between the layers of the aorta. An aortic aneurysm is like a balloon-like protrusion of the aorta. The textbook presentation for this, and actually the ones I have seen in the field, do present with like sudden onset tearing or shearing back pain. And if you think about it, like, where does your aorta sit? Does it sit more anterior or posterior? It's more posterior, right? So it makes sense that they don't have like, they probably can have some chest pain, but it makes sense that they present with like a sudden onset of back pain that's right in the middle of their back and it feels like something is tearing or shearing. That's not going to be referred like visceral, or that's like just going to be straight pain from the aorta tearing
Preferred pain would be like your gallbladder.
up to your shoulder. Yeah. Okay, you see the different grades, and there's two different ways you can, I mean, between a dissection and an aneurysm. An aneurysm is just that balloon that's popping out, impeding. A complete dissection is pretty tough. These guys need a surgeon. They need blood to keep them alive, and then they need a surgeon to take care of this.
You guys want a stupid fun fact?
Yes.
Okay, so in the context of trauma, if they have like some voice changes or like maybe even like muffling of their voice, that could help clue you into an aortic problem, right? Because one of the nerves that innervates your vocal cords actually comes down and wraps around your aorta and then comes back out.
Really?
Yeah.
That's cool. Okay. Signs and symptoms: pain in the chest, abdomen, or back. Flew into that tearing back pain. Signs and symptoms of shock. Why are they shocky? Because you don't have a adequate distribution of blood where it needs to go, right? Like it's tearing and going into other places. And then differences in pulses or blood pressure between arms or legs. That's a big one. So all my chest pains and back pains get bilateral blood pressures. And if I have a substantial difference, and I don't mean like 5 points, I mean like 20 or 30, I need to start thinking about a dissection.
Is that BP between legs, so bilateral, so one arm less than the other arm, or arms and legs different? Like arms is one unit versus. I know it seems like silly. But.
No, it's not silly. Generally it's between arms. Generally it's between arms.
So
I don't know if it would be the legs as well.
No, right, because like think about your vasculature and your pressure, right? The pressure up here is going to be higher than down here, right? Because this is for living, right? But we are comparing, you're looking at like left versus right.
Okay.
So I always tell all my new guys, man, like I think part of a routine assessment should be bilateral blood pressures. It's quick, it's non-invasive, and it can give you a lot. 90% of the time it's not going to tell you anything, but the one time it does could make the difference. That's also like for those of you that went through and we were working on trauma assessments, I said you should feel bilateral pulses at the same time, right? Because you can feel the pressure changes if you're feeling it at the same time. I don't know how to play her videos.
Nobody does. I'm still not convinced there's even videos.
Billy, you don't know how to play these videos?
Nope.
Yeah.
You want me to get the pointer?
Just put them in there to feel it.
Yeah, that, yeah, I don't think he's giving that up.
Start drawing stick
See? Commotio cordis is very rare. Who remembers the Damar Hamlin case? Everyone remembers Damar Hamlin? Okay, that football player that, like, I think he was making a tackle, got up, and then immediately went into cardiac arrest. Dude, this is super, super, super rare. But if you catch this in time, these people have a very high likelihood of surviving this. Okay, like, if you shock them fast enough, their chances of coming back are probably one of the highest in most cardiac arrests. Okay? Yeah, I mean, if you can shock them back fast enough and restore like a normal heartbeat, yeah, they can come back with fully neurologically intact with no issues. Like Becca says in here, it's uncommon. It's caused from a chest wall, trauma to the chest wall when the heart is vulnerable, and then your patient's going to go into one of the two, VTAC or VFib. The definitive treatment is CPR and defibrillation. Does anyone need this? Yeah, no worries. And it literally is so rare because it has to hit at the exact right time to cause that heart to go into that.
Can you pull up that video?
The Damar Hamlin one?
Yeah.
Probably.
He plays for the Bills anymore, but he was playing.
Been
for
on the Bills.
Oh, Bills.
Didn't they shock him on the field?
They did.
Yeah, they started CPR right away and
Number 3. Boom.
oh, oh.
Impact to the chest wall,
Yeah, shoulder right too.
right at the right time. Dead right there. And you guys know it doesn't take a lot of force to do this. Couple different cases that have come out of this is like baseballs to the chest, right? Doesn't take a lot of force. It just takes the timing. There's a couple of them that have happened in like karate matches where they get kicked in the chest. So we always like youth sporting events. We're always just like, it's an easy call for us, but you should always have your little spidey senses on, because like if this happens, you don't have long to act, but if you act, you can make a difference. Abdominal injuries can be open or closed. Internal bleeding can be severe if organ or blood vessels are damaged or ruptured. An evisceration. Do you think that's a real injury, or is that like Pete's chorizo thought out?
Is that a kid, or is that like a wrist?
I think that's a mannequin. I don't know. There would be a kid that.
It looks like it's down by the hip too. We're like, oh, is that a chest? Or what is that?
I think, is that like a? Yeah, you think of like a.
I think it's fake.
I think that's chorizo.
Yeah, I think that's Pete's chorizo. Pete's. Blunt trauma to solid organs can cause life-threatening blood loss. We know they have more blood and vasculature, and they have less ability to expand and contract, with a higher likelihood of rupture. Injuries to the diaphragm can cause detachments, allowing abdominal contents to enter the thoracic cavity. If hollow organs are injured, they can spill contents in the abdominal cavity, and this can cause severe irritation, peritonitis. Sorry, does anyone need me to go back? I punched through that quick. One more? Okay.
Like totally unrelated, right? But like, have you guys all seen agonal respirations?
Yeah, I've seen it in real life.
Yeah, like real life or video?
Yeah.
Video.
Videos.
Is everybody yes, or is anybody never seen that?
I think you demonstrated
It's okay,
it to us
yeah.
once also.
What's that?
I'm pretty sure you demonstrated it to us once.
I do every day. If you haven't, like, go watch a video of it, and then I'm trying to find the video right here. Like, you got to be a little bit careful with it, right? Because there are cases of like people, they were in cardiac arrest, but like their rate is much higher than what you would normally expect to see, but they are in fact active.
Yeah. The first cardiac arrest I ever saw was like that. It was agonal breathing, but he was doing it enough that it looked like he was breathing, but he was dead. I was also 18 and it was my dad. But now I'm like,
You need a hug, bro.
dude, I would love a hug. I would love a hug.
That's two and five.
You've never offered. Are you offering now?
You need them. I'm
Not
here
from
for
you, not from you. No, but it's a good learning point, right? Because once you see it, you can't unsee it, and it's good. Okay.
Andy said he'll give you a hug.
You'll feel super
I'd
safe.
take a hug.
You'll feel so safe.
I would take a hug. It's legit though. Like he's right. Just because they have some kind of rhythm to it doesn't mean you should discredit that they are in cardiac arrest. Like, I bet you Damar Hamlin, because of how like instant it was, actually had like a rhythmic agonal pattern to him for a while.
He survived that, didn't he?
Yeah, oh yeah, dude.
Allegedly. It might be a replacement now.
Oh my goodness,
So
dude.
parasitic situation is peritoneum?
Or yeah, and generally it's going to be like irritation or infection that causes it. Yeah, you gotta remember, right? Like, the contents in your abdomen or in your intestines are not supposed to be exposed to anything else, right? Think about the pH of the acid in your abdomen. Think about the blood that's an irritant, and think about like fecal matter, right? That should not be free floating in your abdomen. That's going to cause problems. They're going to go septic. Okay, signs and symptoms of abdominal injuries. Pain, initially it might be mild, but then it'll become intolerable over time. Cramps, nausea, weakness, thirst. Obviously, if you have a laceration or puncture wound that you can see, have a high index. So those of you guys that went to this year's trauma symposium, last year's actually had a trauma surgeon that was out there, and he was talking about basically how as soon as the bullet enters the body cavity, like, it's no man's land. We can't really predict where it's going to go, the injury pattern it's going to go, and that's not even not caliber dependent. Like, the best thing that can actually happen to you if you get shot is that you have a clean through and through.
That happen very often though.
I would say less often than not, but
Yeah.
like it happens.
It happens. Like, if you take a 10 millimeter point blank, you have a higher chance, or like a high velocity rifle round, you have a better chance of it going through and through. But like low caliber
Like a
handguns,
22 will bounce around off your bum.
yeah. Even 9 millimeters though,
Yeah,
right?
they do the
Even
same
9
thing.
millimeters, unless they're like a really hot, high velocity hollow point, most of the time they're going to go in and bounce around.
Now with all the shit that's going around, they're made to just blow it inside.
Yeah, no, these bullets now are designed to be lethal, which makes our job harder. But also, the odds of surviving a handgun injury or like a handgun wound is actually pretty high. Yeah, you're like, unless you get hit in the wrong spot, like, your odds of surviving it are pretty high.
What about those home protection ones that they have now?
What do you mean? Like, what kind of round?
The 410 is like this long, it has 3 discs with the pellets behind it.
Yeah, I haven't read like the studies on them, but I mean, the more shit you add and the more diameter and velocity, the lower your chance of survival is, right? The more it's going to rip through, the more, and it's, you
I'll
know,
bring one.
with bullet wounds, you got to remember, it's not just the bullet itself. You have several injury patterns, right? You have the cavitation, the expansion, the things around it. Like our friend, like, he shot himself in the abdomen, right? And he did go through some organs, but and he didn't hit his lung, but just the force of that was enough to collapse his lung. Like, he did not have a chest wall injury and an open chest wound. It was enough to collapse his lung bone. Yeah.
He shot himself?
Yeah, on accident.
That happened.
I
I had a guy that when I was in the Army, he shot himself
On purpose or on accident?
on accident.
Sick.
You didn't say every MP on the base was there.
Yeah. All right. Obviously, any signs and symptoms is also going to be indications of blunt trauma, shock, coughing up blood or vomiting blood, rigid, tender abdomen, distension, or the patient tries to lie still. So somebody tell me, why would we have rigidity or tenderness or distension?
Someone's hemorrhaging into their abdomen.
Right, so what happens with that fixed cavity? It's going to get hard, right? Yeah. This abdominal pain is one of my most like unfavorite calls because there's so many different things it could be. They're kind of hard to diagnose without like scans and lab work. And they can be life threatening. So they're kind of tough in that, but for us, it doesn't really change. So we're always going to go through our ABCs no matter what, right? That's first and foremost. And if you get stuck on those and can't get to anything else, that's fine. As long as you're working on the ABCs the whole time, let the patient sit where they're comfortable. If this is the position they're comfortable in and that minimizes their pain, then let them do it. And then treating for hypoxia and shock is part of your ABCs. Don't let them eat or drink anything. Like, yep, NPO is what is it?
PO is per ossa.
Oh, for the
by
mouth.
mouth.
Yeah, by mouth.
Yeah.
Yeah, so don't let them eat or drink anything. Why? They're gonna go to surgery, right? They might go to surgery, and that anesthesiologist wants them to have an empty stomach to reduce their risk of aspiration. Okay? Monitor and transport.
Whenever you're going through like your patient assessment and stuff, like do you take them out of their position of comfort to just assess, like to palpate their abdomen and then let them return?
Yeah, I think that's going to be provider dependent, but I do, right? If I'm looking for something specific and I need to know, I will definitely push to be able to do that. Yeah. Granted, if they're like, no, like you can't push on it, then that's okay. But if they will let you conduct an assessment, for sure conduct the assessment. Nothing by mouth. Okay. I just needed to click one more. Open abdominal injuries, control external bleeding, and dress all wounds. Do not touch or replace eviscerated organs, right? We're not surgeons. We're not shoving stuff back into the abdominal cavity. Apply sterile dressing moistened with sterile saline over the wound site. If it's wet, keep it wet. If it's dry, keep it dry. Okay?
Can you like take down there on the dressing so it's not like sliding around? Or will it stay like if you're testing it?
Yeah, I think that's going to be case to case dependent. If you can, right? Like if you can like do some sterile gauze or like the big sterile abdominal pads and place it over, and then you have something that you can place over it to hold it, then great. If it's big enough, you're probably not going to have that. You can certainly try. For large eviscerations, maintain warmth by placing layers of bulky dressing over occlusive dressing. Okay, we're still treating for shock while we're doing that. Oh, cool. I like this. Okay, patients with gunshot wounds to the lower ribs at the same level in the back should be treated for both chest wound and abdominal wounds. Bullets often don't take a straight path. Okay, they're hard to predict. Caliber to caliber, injury site to injury site, bullets are really, really hard to predict. And if you see the pattern down here, you can see the temporary cavity. That's that expansion that comes from the force, not necessarily the bullet path, but the force that is behind it. Bullets fragment, like Andy was just saying, right? They've developed all sorts of high-tech rounds now. Like I personally carry Hornady critical defenses, and they mushroom and expand. Okay. How silly do you think it would be to get somebody with a gunshot wound and like, I don't know, let's say not find an exit wound or miss other gunshot wounds?
What do you mean, sorry?
Like, do you think like if you brought somebody into the ER and you're like, hey, they got shot twice in the abdomen, but they were actually shot 4 times and you just missed the other 2. Do you think that's common or not?
If you mistake entrance wounds for exit wounds.
So I've actually done that. Like I've rolled people into the ER and be like, hey, they were shot 3 times. This is what I got. And then the doctor goes and finds two more bullet holes. And I'm like, I don't know how I missed that, but so just do good, thorough assessments. Don't get distracted.
I mean, but if you're focusing on the ABCs, that also makes sense. Like you're like, well, shoot, I'm trying to bag them.
Yeah.
it's just me and the driver, like, I know there's at least this many.
Yeah, it happens. Have you ever done that, Mike?
Yeah, I've done it. Like I mean, don't get me wrong, like it's human, but and even to your point, like it's part of seeing.
Yeah, it's
Right,
part of
like, and don't be fooled, like your traumas, especially that type of trauma, I would argue all trauma, but like the whole, like strip them and flip them, like you need to strip them and flip them, right? Like I've caught holes coming out by the rectum that like you would not have caught had you not pulled their clothes off, flipped them and like kind of looked down there, right? Like, so don't, like when it comes to this specific argument, like now is not the time to scam.
Yeah.
Like pull their clothes off, right? If you have, I'm not telling you to like strip every fender bender you have, right? To be clear, but like when the mechanism is there, you need to strip them and look.
Yep. Now I have done it, right? Him and I actually had a guy that was stabbed like 7 times in the back, and he had so much. He was covered head to toe in blood, and he actually wanted to foot race us in the street. He was like super intoxicated, had been stabbed 7 times, covered. And as we were getting him to the gurney, he's like, "Let's have a foot race." And I literally got so tunneled in on like the couple stab wounds I could see and getting an IV. I was so hell bent that I missed the other like 5 stab wounds.
Where were they predominantly located?
So they were all defensive. So he had his girlfriend pinned to the ground, beating her up fairly severely. And then she reached over, grabbed a kitchen knife, pulled his head down, and stabbed him in the back 7 times.
They were localized.
They spanned from like scapula,
Like, all over.
yeah, all over his
She got
back.
me pretty good.
She did. And same, right? Like it wasn't a thick knife, it was a long knife. So like you looked at the wounds and you're like, damn, how much blood came out of this? Like these were small, but there was a lot of them and they were deep.
Yeah,
Okay,
that's kind of the other thing about knives too, right? Like knives specifically, like don't be fooled by it, right? Because at the end of the day, like you have no idea how long that draft is unless you're ballsy enough to put a finger in it, which you shouldn't do, right? Like, and if you ever see it at the ER, like they'll commonly take like a Q-tip, like the long Q-tips, and stick it down in there to see how far that track goes to try and get a gauge of like how deep it actually is. But don't be fooled by it, right? Because like you look at it and you're like, oh, that doesn't look that bad, right? It looks pretty shallow. But for all you know, it's like a long skinny steak knife, and like, no, all 6 inches of that knife went in there.
Yeah. And now you're clipping vessels, lung, heart, right? You have subclavian arteries that run through here. Like it's a
Taking
lot.
that guy survived. He wanted to foot racing.
No, he did survive actually. He survived and he was I don't know if he went to prison, but the cops came back because we didn't know actually what happened. And he was like being super combative. And the cops were like, dude, this is why you're a pile. I'm going to tell the story now. You're a pile. So the cops came back and they told us like, hey, we're going to arrest him because these were defensive wounds and he was like trying to kill her. And we're like, oh, really? And like, yeah, we're going to arrest him as soon as the doctor says it's okay to. So Mike Hoover actually left, went to the store, grabbed popcorn to bring it back, and he pulled up 2 chairs for me and him to watch this guy get arrested because he was being a dick and wanting to fight us. And he was wanting to fight everyone. He wanted to fight the cops. And he was like, don't take her to jail, all the stuff. So we're like, oh, great, he's going to fight. He just got stabbed 7 times and now he's going to get tased. Cool. So we pull up our chairs, we grab our popcorn, and we're eating popcorn.
It was Campbell.
It was Campbell. And I said, Campbell, you can't arrest him yet. Mike's coming back with popcorn. So the cops waited for us to get back with the popcorn. We pulled up our chairs, and then the dude, they're like, hey, you're going to jail, right? Like, you were attacking her. These are defensive. And he's like, you can't take me to jail. And he's getting all hyped up. I'm like, yes, he's going to get tased. Anyways, the dude, I remember he told the cops, he's like, you can't arrest me because who's going to feed my lizard at home? Have you thought about that? And Campbell goes, oh, man, I didn't. Put your fucking hands behind your back. And then he didn't fight. So yeah, we're like, the lizard. Who's gonna feed the lizard? It was so funny. Yeah, Campbell's like, oh man, I didn't think about your lizard. Put your hands behind your back. And I was like, oh, this job is a dream. Okay, trauma.
Popcorn.
Oh, dude, we were expecting so much more out of him. Yeah. All right, the triad of death and trauma. Important because this directly like this shows us why we should be treating for shock. And it's such a small thing, treating for shock, and everybody overlooks it. And you know who overlooks the worst? Paramedics. Paramedics are the worst at treating for shock because for some reason they believe they're above it and they always miss a step. But guess what? If they get hypothermia, they cannot form a blood clot, right?
Nobody can see.
Oh yeah, pointing, thanks.
Yeah.
So if they get hypothermic, they can't form a blood clot. If you have lactic acid buildup, you have an increase of acid in your body. That decreases your heart performance. Okay? This is I wish it was a circle instead because they just play into each other over and over and over and over. So treating for shock is important. Keep them from getting hypoxic. Get them warm and transport them rapidly.
Yeah, like I actually like these versions of this, right? Like this should be a circle, like, and just to make sure you guys understand and never forget, that's just remember, like, it goes both ways.
Yeah.
Like, it's not just linear, like, oh, if I start here, then it will get me here, and then once I get here, then it does this, like,
It all plays off of each other. So remember, treat for shock. Do not skip, do not skimp.
You go to the last slide.
I can. Let me.
You ever hear what happened to the lizard?
I don't know. I hope it's okay.
Right?
How long ago was it?
Oh, years, dude. I mean, I was in advance at the time.
Because you said you don't want to go stick your finger in things like that. Would you pack those still or no?
If they're bleeding bad, yeah. Well, yeah, not
in the
like
arms and like legs.
yeah. If arms, legs, then yeah, you would pack them, right? Junctions, but like if they're in the thoracic cavity, you wouldn't. What's up? No, I wouldn't pack it because right on the back side of that, it's hollow, right? It's your thoracic cavity.
So not even against like the scapulas, like you said?
I mean, you can put gauze on there, right, and hold a little bit of pressure, but I wouldn't be packing it, you know? Yeah, I don't think some direct pressure is bad. If you're looking at it and you're like, man, that might be sucking, that might not, just throw a chest seal on it, right? So what? You threw a chest seal on someone that didn't need it, whatever, not a big deal.
Do we have another presentation?
Did you look on the schedule? Was there another one
No,
today?
I think it was just this one,
No,
because
just
they're
one.
gonna break and do some stuff.
The next few are the same one.
Can we go over like some of the signs and symptoms for each of this triad and how we would treat for it, like IRL? So like hypothermia, give them a blanket.
Yeah.
Acidosis,
You're not.
Well, oxygen, right? Because you're trying to get them to breathe it off. Like, isn't acidosis just from like carbon dioxide buildup?
see discussion.
Okay, so restate your question. No, oxygen is not going to directly, because oxygen is not going to directly impact your acid levels. Okay, oxygen is just going to keep them from getting hypoxic.
So why, like, what causes a trauma patient to go acidotic?
Okay, good question. Their lack of clotting factors then leads to. That's such a bad habit. Honestly, Mike is better at explaining the physiological side of this, but I would say in like a bird's eye, right? Like they get cold, they can't clot. They can't clot, their proteins denaturize, and then you're releasing acid into the system. Would you say that in a different fashion or?
So
No,
acidosis.
I would say, like, to your point, like, you're not necessarily wrong though either, right? Like, what do I need for my cells to perfuse and do the thing?
You need oxygen.
I need oxygen,
Yeah.
right? Like, so hence why you're gonna give people in shock oxygen, right? Like, into Mikey's point, like, by feeding them full of oxygen, you're not necessarily going to be like reversing acidosis, right? Because the other problem too is like, I can stick 1,400 breathers on somebody, but if they are just pumping all of their blood into their chest cavity, is that circulating around and delivering it?
I think what you're talking about more is like ventilation, right? And how when you're breathing off carbon dioxide and that carries acid with it, right?
Because you're like, you're taking that waste product, which is
Right.
Yeah.
Well, and
That's-
that's,
that was
remember,
trying
like
to
that,
take it
that
out.
waste product is now building up because of a lack of perfusion all over the place now, right? And you're not wrong, hence why, like, when I go into shock, regardless of what that is, like, I'm going to start breathing faster.
Yeah.
Right, because I want to bring in more oxygen to use, but I also want to start blowing off CO2 to help compensate for the acidosis that I'm now going to build up, because I'm no longer perfusing it as good. And eventually, as it goes and goes and goes, like, that becomes overwhelming and it's too much. You're out of blood now. You're no longer perfusing any of it, and then it's all going to stop.
Okay, so in trauma, the reason for acidosis is hypoperfusion, like not being able to produce.
Yes.
Well,
Yes. Yeah. It's not being able to perfuse. Yeah, which you're right, oxygen will help.
7.
Oxygen will help, but it's really not going to directly change your pH balance.
Okay.
But what can, the big one, I mean, so oxygen is, but like keeping them warm or at least normothermic, that will take you a long way.
Yeah, and same, like, I mean, this kind of sounds silly, right? But it's not like, oh, I took their temp and it's 95, I should give them a blanket. Like, even if their temp's 98.8, like,
Give them a blanket.
they're getting the blanket.
They're getting the blanket. So a good rule of thumb is that if you're working a trauma and you're not sweating back there, it's not hot enough, right? It does suck. It sucks when you're working a hard ass trauma and you're roasting back there and your patient's still like ashen gray and cold to the touch. You're like, oh, damn, bro.
So a blanket is to hypothermia, as oxygen is to acidosis, as what is to coagulopathy.
Still temperature, right, you said, if they go.
So the coagulopathy is just referring to, like, they are now starting to have a clotting problem, right? Because one, they're bleeding, so they're losing it. But then two, like, what they do have left, like, they're trying to use up, right? And it's kind of the same, like, you only have so much of that too.
So just like bandaging or minimizing. the
Yeah, right,
bleeding
like,
or-
yeah, stop the bleeding, like, whatever bleeding you can stop, like, stop the bleeding, and
No,
then
'cause you
that's
want
kind of the
it.
extent of it, right? Because to fix that, like, you need blood products and all kinds
Yeah.
of crap that we don't have.
Yeah.
Maybe something.
Maybe someday. The state of Nevada right now is not on board with it. And they just released their new medications list, and it is in very bold parentheses. Blood is only to be continued by paramedics, not initiated. So that's an uphill battle. Yeah. And a lot of this stuff, like, you really don't have a treatment for. A lot of the stuff we don't have a treatment for. Anybody else want to go over anything? Oh, someone's got a question. Come on. You're done with questions?
HR says we're done, sorry.
HR? You HR now, Lincoln? This is chief of finance over the region.
Even worse.
This is how you pay Lander County EMS.
Oh, shit.
She's the one that makes them or breaks them.
She does. Huh?
You ever get leaking at Jesse's?
Like, you know, whatever she wants, bro. She's the one who always funds our projects.
Okay, so is she the one who decided?
That's why that one threw me off.
to give us the shorts that we can't wear?
That was not.
They can decide
No.
to feed.
I want to wear my shirt. But what I'm saying is, like, you can't wear it on calls or anything.
That was not my decision.
Okay, just asking.
That was-
Sorry, Lakin.
I'll just tell one. That was
The
my
funding
decision.
To buy the shirts.
Yeah.
that you can't wear.
You know how many times I've been like, hey, Baker, let's buy this stuff. And Baker's like, yeah, let's buy it. And then we go into Lakin's office and she looks at us like, we're dumb.
I only told you that one time.
And I remember it forever. Yeah, I wanted to buy a side-by-side ambulance. I was like, hey, let's get a side-by-side
You just got
ambulance.
a regular ambulance. That's why I told you no.
And me and Baker were like, yeah, he saw one at Mardi Gras or wherever he was, and it was super cool. And I was like, yeah. And then Lakin's like, you guys are dumb. And I'm like,
Laken's like, no eating for 2 days.
Yeah. Dude, we need a bomb robot.
Like, they go in to get patients out.
I'm in.
They could use them to grab the electrical. lead out of the way.
Okay. You guys, no questions? Okay, so then before we leave, we're gonna do a little pop quiz. Which organs are? What are you looking at me for, dude? Which organs are more dangerous, are more life-threatening if they receive an injury, hollow or solid?
Solid.
Okay, good. Difference between a tension pneumo and a normal pneumo. Okay, what is your telltale sign of that? JVD's late, but it is one of them. Tension pneumo versus normal pneumo. Normal collapsed lung versus tension collapsed lung. Good, decreased blood pressure, right?
Absence of lung sounds unaffected.
You can have that with a simple pneumo too. Granted, the worse the pneumo gets, the more diminished you're going to be, but it is going to be your blood pressure is going to be the one that dictates that. Okay? Guys, I think this is our last hoorah before Chaz and Becca give it.
Are they coming back?
I think you guys will be teaching that. Chad said they're not gonna be back.
What's today? Is today not Thursday?
Today's Tuesday.
Dude, you just came back from work today.
That's
What happens
crazy.
when you have a lot of time off?
Saturday too?
What's that?
Are we gonna get you guys Saturday?
I mean, they'll be, Chaz and Becca will be here Saturday, but I imagine.
I won't be here on Saturday. I'm taking my Saturday off. No, yeah. You won't either. You're off too, huh? So this is it, guys. We have next on Thursday, and that's it, dude. Our last.
Come on, man. You buy this minivan, you're just lost in time.
Yeah, dude. I don't know why I thought it was Thursday. already.
Oh.
Rose been standing on
What's up?
West Coast Road.
No, I think so. I think so.
I'll text him
I
tomorrow.
went into his office the other day to tell him that we had class. He's like, get the fuck out. I was like,
No questions, and I'm gonna close out the PowerPoint. Anybody? Anything left? Nothing? Okay.
I walked
I'm
in
gonna throw
and
my
just like,
pen at
looked
you.
one bit.
At me, dude?
Yeah, I got that look the other day when I walked in his office, like, what the fuck do you want now? Like, turned around and walked right back out.
every time I try to leave without saying something, he's just like, no, get back in here. Say what you're gonna say.
Why me?
Thank you, guys.
No problem.
You can tell it yet?